So our next speaker is Scott Fleming. He is a graduate student in the Department of Medicine, Center for Biomedical Informatics Research.
Thank you. I want to talk to you today about a new technology that we're developing in the Wall Lab that has the potential to revolutionize the way in which we triage and diagnose autism spectrum disorder. Autism spectrum disorder is a developmental disorder that affects behavior and communication. It's called a developmental disorder because often it's diagnosed and triaged in the first 2 years of life. And in fact, diagnosing early leads to better prognosis for treatment. And so it's critical that the timing is rapid. However, we face some barriers in the diagnosis and triage of autism in that the diagnosis process can oftentimes take hours for a clinician to review a child's behavior. They have to assess across a spectrum of different types of behaviors, including communication, social skills, atypical or repetitive behaviors. And so you can imagine in many cases, this process is inaccessible due to a lack of trained clinicians or proper care. For example, Bangladesh, which is the site of our study that I'll be talking about, in Bangladesh, the ASD prevalence in rural areas is 0.15% to 0.8%, and it's actually higher in urban areas. Now, lest you think the prevalence actually differs between these two areas, many studies suggest that, in fact, this is because, for example, in one urban hospital in Dhaka, people pointed to an increased awareness amongst parents and better access to care, which leads us to the question, can we do better? Is there a way in which you can imagine a parent takes a home video of their child, uploads it to a portal, and you have a team review the video, annotate the video, and then this is passed through a machine learning pipeline to generate maybe not a diagnosis per se, but at least in a first pass, a triage, so you can give the right patients the right care at the right time. So in particular, we've developed a pipeline that allows a parent to upload their video. This video is accessible via web or mobile. A reviewer rates the video on a number of different questions. These annotations are fed into a pipeline that has a classifier built for the rater that assesses the risk of autism for that particular child. Recent work by our team has allowed us to demonstrate that we can have an AUC, which is a measure of predictive accuracy that takes into account sensitivity and specificity, of 0.92. So this is a promising first pass. The question is, though, American resources are much better than other parts of the world. Can we extend this work to the developing world? In this case, Bangladesh. Just to give you an idea of what one of these videos might look like, I wanted to play for a moment what the video rater might see. So they see the child in the video, and they see the questions on the right-hand side, and they can rate while they're watching the video and interactively scroll back and forth in the video responses to each of these questions. An important note here is that our raters are not actually clinicians, nor are they medically trained. They have minimal training, but nevertheless, ensembling or bringing together their annotations allows us to achieve the powerful results that we demonstrated in the previous slide. So our data set in this case, we collected 159 short home videos, each about 3 minutes, of Bangladeshi children, many of which had stunting, putting them at risk for developmental delays. Approximately a third of them had autism spectrum disorder. Another third had a speech or language condition other than autism spectrum disorder. And the other third were healthy controls, who may or may not have had stunting. 6 American raters with minimal training gave responses to 30 questions about the child's behavior while viewing each of these videos. For each rater, we trained a personalized model to map from their annotations to an autism spectrum diagnosis. Important to note is that the raters themselves did not give an autism spectrum disorder diagnosis, or at least I should say they did, but this was not incorporated as part of our model. These models were built in 2 stages. In the first stage, we trained a model to predict whether or not the child had a developmental delay, and in the second stage, we trained a model to predict whether or not the developmental delay was autism spectrum disorder versus another condition. And we used a novel weighting scheme that I won't have time to talk about now, but I'm happy to answer in the Q&A, to ensemble these rater models together. What you're looking at here is the performance of our model. So in this case, on the left-hand side is the first stage of the model, where we predict whether or not a child had normal or abnormal development. And in this case, of the 30 children who had a developmental disorder, we correctly identified 90% of them, while at the same time being able to screen out 5 children correctly who had normal development. On the right-hand side, you'll notice that our stage 2 classifier, predicting whether a child who was marked as having a developmental disorder had ASD or not, also performed well, achieving an AUC of 0.87, comparable to some of the models we've seen for American raters rating American children. And in this case, of all the children that had ASD, or that were predicted to have ASD, 100% of them actually had ASD. So our model was highly specific for ASD. But of course, we can adjust in these raw numbers the sensitivity and specificity thresholds according to the particular application needs. In terms of a machine learning model in a clinical setting, an important question to ask is, what is the model actually learning? And this is critical for helping the clinician and the parent understand what aspects are going into this high-risk score. Interestingly to note, if you look at, as one example, our ASD model, the top 4 features were representative of what you might imagine from a clinical perspective being important for an ASD diagnosis. For example, question 1, does the child stare at or fixate on, for long periods, on particular sounds, smells, or textures? Number 2, does the child display repetitive interests or stereotype behaviors? Number 3, describe the child's level of eye contact. And number 4, does the child look up and pay attention to the examiner or caregiver when they talk to the child without having to call the child's name? We have here on the y-axis for each one of these questions the impact of the response for an individual child's annotations on the model's predicted probability of the child having autism spectrum disorder. So, for example, for this question, does a child stare at objects for long periods of time? For those children where the video rater annotated the child rarely does this, you'll see here is no effect on the model's output. Those children that rarely fixated tended to have a decreased probability, according to the model, of having ASD. If we look at the second question, does the child display repetitive interests or stereotype behaviors? Those children in which the behavior was observed during the entire duration of the video, that annotation tended to increase the model's predicted probability of the child having ASD. Whereas for those who were not observed to display this behavior, that tended to decrease the model's prediction, a predicted probability of the child having ASD. And you can see similarly with these questions 3 and 4 in terms of feature importance, our findings of describing the child's level of eye contact being important and indicating that the child does not have ASD is aligned with our clinical understanding of the disorder. In summary, these results show the promise and potential utility of a method in which we can triage and allocate resources to those children who are at greatest predicted risk of having autism spectrum disorder, allowing us to prioritize and deliver those treatments as timely and efficiently as possible, even in the developing world, and even when the raters are not necessarily of the same culture, language, or background as the children that they are rating. This, I think, was a surprising and exciting result for us, and we're in the process now of pushing this pipeline into full production and testing its results in a prospective validation cohort. I'd like to acknowledge some of the great work that's been done here. I am a representative, I suppose, for this work, but at the end of the day, what I've done is just the tip of the iceberg. There's been a phenomenal effort by the team to put together all stages of the pipeline. I'd like to thank the grant support to Dennis Wall and the lab from FIND, HAI, the NIH, and the Hartwell Foundation, particularly for the Maternal and Child Health Research Institute for this speaking opportunity and the opportunity to present our work, and also for the NIH for funding me as a graduate student. I appreciate your attention and I'm open to and excited to hear your questions.
Okay, I have a question.
Please.
I was wondering if you could please elaborate on the minimal training that the observers receive and how you envision that playing out in a real-life scenario.
Absolutely. So you can imagine, I'll jump to the first part of the question, which is how you can imagine it playing out in a real-life scenario. We, for example, right now are working with workers on MCHRI, Amazon Turk, who go through a minimal training in order to be able to understand the nuances, but you can up or increase the amount of training required for these readers as necessary for whatever the clinical needs are. Now, the raters in this particular case had some coaching, for example, as to what one of these behaviors might look like. And you'll notice also in one of the previous slides there was an option for them to click on a question that would clarify what the question was asking. And so if they had a question about like, what is a video where a child displays this behavior, we could provide that to the rater. But in general, we also try not to bias the rater by providing so much information that they are either too sensitive to ASD and always jump to ASD versus another developmental delay. And so what we're finding is by being able to adapt each model to the rater specifically, we're able to capture what the rater does well naturally, rather than forcing them through training to capture what we think is the most important aspect of ASD. So the nice part about this pipeline is you may get certain aspects of autism that you didn't necessarily know were important, but that are captured just by utility of being useful in the predictive model. Mm-hmm. And that's learned automatically.
That was terrific. I don't know if you can hear me.
Yeah.
Can you hear me? Okay, great. So on the question I had was, there was still a certain amount of misclassification that occurred.
Yes.
And were you able to increase the accuracy of the prediction if you had repeated observations of those kids over time? Because I can imagine you're getting a snapshot, although it's a video. So those behaviors may not be consistent over time. Did you look into that? And then I have a second question for you.
Yeah. We did not look into the longitudinal aspect of this, so we don't have follow-up videos on the children. Mm-hmm. And so I was not able to assess that. But you can also, we did have some issues, for example, where the video quality mm-hmm. may not necessarily have been sufficient to accurately assess each of these individual behaviors. So to the extent that we can work with the people providing the videos to make sure that all aspects that might indicate some important feature of autism are there, we might be able to get a better accuracy. And so that's something we can look into.
Yeah, thank you. And then the next question is, what do you do once you detect? So what's the next step from there? And do you have a path for them to follow?
Absolutely. We currently, that's an aspect that we are currently not necessarily focusing wholeheartedly on. I should say we are primarily focused on the pipeline itself. And I would pose that question actually to the clinicians and to the healthcare systems in the room. How do we, for example, incorporate some of these findings from technology into the clinical workplace so that we can make sure that we're allocating the resources appropriately to the right patient at the right time? And I am afraid I don't have a better answer than that for right now.
Okay, thank you.